Good afternoon, everyone. This is Amanda from NYACP. We'll get started in just a few short minutes, just waiting for everybody to join. We're scheduled to start at 12:15. This is Amanda again. I think we're just going to give a few more minutes for some people to join. I know it's lunchtime, so we'll give them a chance to grab their food and sit down at their computer. So we'll start in just a few minutes. Thank you for your patience. All right, everyone, I think we're going to get started. Thank you so much for joining today's webinar. It's the third in our Cost of Care series, and we're really happy to be able to show you new cost of care tools and resources for clinicians that have come out from ACP. My name is Amanda Allen. I'm a coordinator here at NYACP for the Cost of Care Conversations Project. And I'm happy to welcome our speaker today, Dr. Jessica Dine. She's an associate professor in the Division of Pulmonary Allergy and Critical Care and is also the Director of Evaluations and Assessments for the Department of Medicine at the University of Pennsylvania. Her clinical focus is on consultative pulmonary medicine, and her education role focuses on the development of robust evaluation systems and improving residency training related to high-value care. You might recognize her name. She was the co-author of Tools to Help Overcome Barriers to Cost of Care Conversations. That was in the May 2019 Annals of Internal Medicine supplement. And she assisted the ACP National in creating the cost of care resources that she'll share with us today. Those are also available at acponline.org. Just before we officially begin, just have a few guidelines to go over. Of course, as is standard nowadays, all participants are going to be on mute. We gave the opportunity to submit questions upon registration, so we have those, and hopefully those will be answered for you as we go through this presentation today. If you didn't get a chance to ask a question, or if you still have another one at the end, please go ahead and type your questions in the dialog box on the right-hand side of your screen, and we will go ahead and get them answered. If we run over the time, we want to keep you on time. Just submit your answer, and I will get an answer to you via email. There'll also be a recorded version of today's webinar that'll be posted on NYACP's website. It'll be on our Patient Empowerment Resources page, which is under the Practice Management heading at nyacp.org. So I am going to officially now turn over the controls to Dr. Dine, and we will get started. So Dr. Dine, I am going to pass controls over to you. There you are.
Hi, everybody. Thanks, Amanda, for that nice introduction. So as Amanda has already told you, I'm a pulmonologist at Penn, but I collaborate with the ACP on several initiatives related to high-value care. The resources that I hope to show you today are from a project that the Robert Wood Johnson Foundation funded. They funded 8 different pilot grants about cost of care conversations with patients. And the ACP was involved in translating the findings from those 8 pilot grants into resources that clinicians and practices can use. And what I want to do is show you those today. Let me just start by saying that I fully acknowledge that that our system is broken, and that ultimately what we would like to see is that we improve the cost of care and the transparency. But in the meantime, these resources are there to help you and some workarounds. So first, we're going to just briefly talk about financial burden, because I know you've already had several webinars related to the topic, and then we'll talk about how a clinician or really anyone in the office or at your site can be involved in having these care conversations using the resources that we've developed that are freely online on the ACP website. So let's start with, what do I mean with financial distress? I just want you to take a minute and just think about the last time you came across a patient that you thought was troubled because of the cost of their health care. How did you know, and what did you do? I think that we've all had patients that have expressed concerns of their health care. I always like starting with a patient story so that we don't forget about them. So let me tell you about this couple. So this is Andrew and Famiko on their wedding day in 2006. She was working in the entertainment industry at the time, and he was a PhD student when he was diagnosed with a neuroendocrine tumor. He had student health insurance, but despite having insurance, he quickly reached his $5,000 prescription limit. And just to pay for his medications, he ended up paying out of pocket $300 a month. And that quickly escalated as he needed more and more medications, more costs. He became sicker, so his wife quit her job, took care of him. They moved in with her parents. He actually finished his PhD, became a faculty member at the University of Michigan, had better health insurance, but continued to rack up healthcare costs because of out-of-pocket costs. Unfortunately, 3 months later, he died, and she was left with thousands and thousands of dollars of medical debt. Even though I'm starting with a sad story, she actually ended up going back to school, and she went back to medical school, is now a radiation oncologist, and spends her time researching the impact of cost of care for patients with cancer. So this is one of her papers. So this is a research letter published by Dr. Chino in JAMA Oncology, where they looked at 300 patients with a cancer diagnosis at Duke. And basically what I want you to see in this table is that there were significant monthly out-of-pocket costs on average. And on average, patients spent 11% of their income on out-of-pocket healthcare costs. And there's a subset in this column here of patients that had overwhelming financial distress. They used a particular scale that if you're interested, I can email it out to you. But those patients paid 31% of their income on out-of-pocket costs. And so this is what I mean by financial distress, that patients experience a significant burden related to out-of-pocket costs of their health care. And what we know now, which I'm sure you all appreciate, is that this has significant consequences on their health. So not only do they report a reduced quality of life, they have more symptoms, but there's a lot of data showing that this actually leads to non-adherence. So patients that we might label as non-compliant might just be unable to be adherent to the recommended regimen. So this is data from 2018, where 35% of adults reported that they either didn't fill a prescription, didn't complete a recommended test, or followed up because of cost of care. Now there's newer data showing that it might actually impact survival. So this is a study published in the Journal of Clinical Oncology, where they looked at patients that filed for bankruptcy. And these are patients with malignancy. And within an almost 20-year time period, almost 5,000 patients filed for bankruptcy. And then they compared them to matched samples. So they used the propensity score. So they matched them based on how sick they were. And what they found is that patients who experienced bankruptcy were 1.79 times more likely to die in that time period than their matched samples. So as healthcare providers or working in the healthcare field, it's pretty clear that having financial distress has a significant impact on our patients. And so what I'm trying to do is give you some resources to help them. So why do they exhibit financial distress? A lot of it has to do with out-of-pocket costs. So in 2000, the estimate was that about 1/5 of all the healthcare costs in the United States were falling on the patients. And why is that? It's because as healthcare becomes more and more expensive, insurance companies are trying to move a lot of that cost to the patient in the form of, for example, deductibles. So deductibles means that a patient has to pay a certain amount before the insurance kicks in. Co-payments, which is a set amount that they owe every time they see a healthcare provider, for example. So let's say $20, no matter how much a physician charges, they pay $20 to see that provider. But there are also some co-insurances where they pay a percentage. So if I charge $100 and they might pay $10, but if I charge $300, they'll pay $30. And then, of course, there are lots of uncovered services. So these are just some examples of out-of-pocket costs. And we'll come back to these, but what I want to point out is that it's rising. So the first data point I told you was from 2010, where 20% of patients, or 20% of healthcare is paid for by the patients. Now, only 5 years later, so 3 years ago, that rose to 24% and is probably even higher now. What makes up that percentage is direct medical costs. So those are the things we just talked about, the deductibles, the co-payments, the co-insurance, but also having to pay for care related to side effects or adverse events. Then there's non-medical costs. So that's, they have, every time they come to see you, they have to pay for a cab or a bus. There's indirect costs. Every time they come to see us, they can't work or they need a babysitter. And those are even harder to measure than the direct medical costs. And then, of course, there's costs such as anxiety and pain just for being sick and having to see their provider. So how do we identify these patients? And should we identify the patients? The first question is, do patients want us to? And so what I want to show you is a study that basically surveyed 133 internal medicine physicians and their panel of patients. And they asked them, do you want to talk about out-of-pocket costs? And not surprising, the majority of patients and the majority of physicians wanted to talk about out-of-pocket costs. Before I show you the answer, I just want you to think in your mind, how many times do you think these conversations actually happen? You probably all were not far off that it didn't happen a lot of the time. We can spend another hour talking about why only 15% of the patients and 35% of the physicians thought that these conversations happened. But what I really want you to focus on, that even though a majority of both patients and physicians want to talk about cost, we don't. We'll come back to why that is. But I want you to think about, how would you identify patients that want to talk about cost when they come to your practice? How does it happen now? Do they bring it up? Do you ask them? So the ACP reviewed this, and most clinics don't have a specific way that they identify patients in financial distress. So the first tool that I want to show you is a cost distress identification tool. This was adapted from the cost measure. The cost measure is a validated instrument for screening patients with cancer, where most of this data is coming from, for financial distress. And basically what we did is we adapted these questions based on the findings of those 8 pilot grants I mentioned to you. To be totally honest with you, they all sort of answer the same thing. So if you were to do a factor analysis, it's one factor. So you don't have to use all 4 questions and sort of pick which ones make sense to your patients, but this just gives you an idea of how you might screen for them. The problem then is, well, what do you do with once you identify a patient that might experience financial distress? Which leads me to the next couple of resources that I want to show you. The way we decided to organize them was to organize them around the barriers to having these conversations. So in that, I'll just show you an example. There's multiple studies, and the ACP actually did its own member survey, and everybody shows the same barriers. So this is that same cross-sectional survey I mentioned to you earlier of 133 internists and their patients. And they basically said, of those of you that can remember why you didn't have the conversation, why didn't you have them? And the patients basically said that they felt uncomfortable. They didn't know how to bring it up, and that they had too many other things they wanted to talk to their physician about, so they didn't have time to talk about the cost on top of everything else. They also thought that, quite honestly, the physicians wouldn't know what to do about it. And although the minority of patients mentioned this, I think it's important to point out that some patients think that it would impact the quality of their care, and they, even if they had trouble paying for it, would want the best quality care. The physicians, basically almost all of them, said, I don't have time. And so some of the resources that we're showing you hopefully will make this faster. And if you, just the cost conversation, the screening piece, that in itself has been studied and takes about 2 minutes. And then finally, the physicians believed that if they did identify one of their patients as needing help, they didn't know how to help them. So what we did is we organized them based on these barriers. And you can see this also online on the ACP website. I'm going to walk you through some of these, but I hope that you take some time and just go to the website and check them out so that you can decide which ones might be useful to you. We already talked about how to actually identify the patient. But what we heard when we piloted this in some centers is that even though they had a screening tool, they didn't really feel comfortable bringing it up. And so with the cost distress identification tool is also a cost conversation guide. I'll show you an excerpt of that in a second. But I also want to tell you that we highly recommend screening every single patient, so that if we all have implicit biases, that we don't make assumptions about who might be struggling to pay for their healthcare. It's better to ask all patients, and I think you'll be surprised by what you'll find. Here's the cost conversation, the first page of the guide, and it sort of tells you some language. It has been studied that patients feel comfortable when bringing it up. And the one that's been studied the most is sort of describing that other patients have had trouble. So as Amanda mentioned, I'm a pulmonologist. So all of my inhalers that I prescribe, even when covered by insurance, tend to have a really high copay. And so I usually tell all my patients when I prescribe one that many of my patients tell me that despite health insurance coverage that includes a prescription pen, these can still be really expensive and can be prohibitive. So I'm going to try to work with your insurance company, but if you get to the pharmacy and it's really expensive, please let me know. There are alternatives. So kind of normalizing that this is something a lot of people struggle with. Then once you have identified people, what resources are available? The ones that I want to point out to you are these two. So the first one is just a list of resources. I've highlighted some here, but there's a ton of resources on the website. I'm going to show you some of my favorites. But they are organized by resources for direct medical costs, indirect medical costs, and then the other medical costs that we talked about. In particular, I really like Needy Meds, the Neighborhood Navigator, and I'm going to show you those in a little bit. There's also a list of online healthcare cost estimators. I'm sure that many of you have tried these out. They by themselves aren't all that helpful, but I'm going to hopefully show you a way that I think it'll make it easier for you. My favorite is the Fair Health Consumer Cost Lookup, the second one listed here. And the reason for that is that it allows you to sort of account for insurance. So the patient can't put in their own insurance information, but you can guess whether they're going to be in network or out of network. And then basically you can type in the test that you want, and it'll give you both an out of network and an in-network price. The problem with all of these for me is that they're not particularly friendly for patients. So I looked up breathing tests, PFTs, pulmonary function tests. And the only way that I could find the right one is by actually putting in the CPT code. And the actual name of the test is really complicated and not at all what we use. So a patient would have a really hard time figuring out how to search for these tests. I think Healthcare Blue Book is a little bit easier in that regard. So you can, in all of these, you can put in your zip code or city, and it gives you the average cost in your area. But here the drop-down lists are a little bit more user-friendly for patients. So for example, here, the pulmonary function test that I was looking for was called breathing capacity test. And I think if a patient typed in breathing test, they would eventually find this. But again, not super friendly for patients, so they're going to need some help, and I'll show you how I use these. The other ones I wanted to point out to you are the medication-related ones. I don't know about you guys, but for me, most of my patients come to me with costs related to medications, especially the inhalers that I already mentioned. And although I'm going to show you GoodRx, which I think many of us use for reasons I will show you, I wanted to just point out OneRx because a lot of people tell me they've never heard of it, and it allows the patient to actually type in their insurance and gives them a better estimate of what a medication might actually cost. This is one that I actually will give to patients. So I tell them, here, go to goodrx.com and go to onerx.com and see where you can find the cheapest medication. So the reason that I still use GoodRx a lot is because it also links to resources. So one of the questions that Amanda gave me was, what do you do with these really expensive biologics, for example? And so here in GoodRx, as an example, I put in a monoclonal antibody that I often use for asthma. And even though GoodRx can't price it out for me because it's not available at regular pharmacies, it does tell me some resources, and there were 2 other listed, I'm just showing you 2, where a patient can go to get help. So either through the company itself or through some grant funding. And typically what we do is the patient looks at them and the nurse helps them fill them out because sometimes they're difficult to fill out. I also want to point to you out MediMeds. So even though it sounds like it should be only for medications, there are a ton of things to look up here for where to get cheaper medications or coupons for medications. It has a lot of other information for patients. So this is another one that I give to patients. So for example, on their introductory page, you can see right away, they talk about durable medical equipment discounts, which is obviously not medications. And if you click on the patient saving piece, you can see there's a whole other area that they can look up for transportation, for applying for grants, and for looking up, based on their diagnosis or where they live, what programs are available. Another incredible resource, I think, is the AAFP Neighborhood Navigator. This one also has a really nice screening tool that's not just about the cost of care, but it screens for any impact of social determinants of health to their health care. So that's really nice if you want to take a look at that one. And then you can actually type here, below here, underneath the getting started, you can actually type in your zip code, and then it tells you all the programs that are available in your area by different categories. So if you were to click here under health, there's actually a category that says to help pay for healthcare. And then it tells you what programs are available in your area to help with both direct and non-direct medical care. But these are nice for patients because, as you can see, they also have other categories unrelated to healthcare probably still related to healthcare, like food insecurities, housing, other transportation that's not related to healthcare, and so forth. So those are some excellent resources. I would play around with them a little bit if you have some time, but you don't really have time to go through all of these with every single patient. So I would play around with them in terms of your goal being, where can I send my patients to? This one, if they have access to a computer, the AAFP Neighborhood Navigator is a fantastic one that you could, if you don't have someone in your clinic who can meet with someone who's in financial distress related to their healthcare, you could send them there to get them started. The other thing I would recommend doing is thinking about what is the most common thing that you see or treat, and then come up with a generic plan of care for that. So for example, for me, I could pick COPD or asthma and say, okay, for my patients with COPD, what would a typical diagnostic or therapeutic plan look like? Well, once I diagnose them with COPD, I will probably get a screening CT if they were a smoker every year, and I will probably start getting PFTs every 6 months and then yearly. And so what I do is I look up those tests on here, on the Fair Health Consumer or Healthcare Blue Book or both, I'll look up a screening CT, I'll look up an unenhanced CT, and then I'll look up different kinds of pulmonary function tests that I might order, so I get an average cost. And I do the same thing for the most common inhalers that I prescribe. So what on average do they cost in our area? So that although I don't have the specifics for every single patient, I have sort of a generic idea. And then the patients in the Robert Wood Johnson pilot said what they particularly struggle with is the unplanned healthcare. So then I think about, well, what could be the times when they get acutely sick with COPD? So I tell them, most likely you'll have an exacerbation, and it happens in the winter, usually when people get a cold. And so at that point, we need to revisit this. But just so they can plan a little bit about what does that look like? Will I need to miss work? Will I have to come in? What should I pay for? And this is just a different way of showing that on the ACP website is actually a cost planning tool, one for you as the physician or clinician, and one for the patient that the patient can use to kind of keep track. This is well studied in both the OB literature and in the oncology literature, that patients really like having what is my next year most likely going to look like, with the caveat that it can change if I get sick. So I've just told you a lot of different resources. I wanted you just to get an overview what resources are available, but I also want you to spend some time thinking about, well, once I look at these tools, how will I actually implement them? Right? We've all been on lots of webinars and lots of CNEs, and we get these wonderful ideas, but we don't actually implement them. So on the ACP website are also resources to figure out, well, once you identify something that you want to work on in your area of work, how do you actually do that? I'll just quickly give you one example, which is the practice level approach that gives you a stepwise tool to go through, well, how do I implement this in, let's say, my outpatient practice? And the first step is really, what exactly do I want to work on, and what are we doing now? So I would start with, let's say that your goal is to actually identify patients in your office that have financial distress related to healthcare. So think about, how does that happen now? How are they identified currently? Is there a process in place? If so, who does it? Is it the patient that's initiating it? Is it a medical assistant? Is it a nurse? And then really think about everything that you do that is related to financial distress identification. Then think about, well, what's the regular patient flow? So if we're talking about an outpatient clinic, for example, what's every single step a patient has to go through? So the patient has to call to make an appointment. Who does he or she speak to? When they get there, where do they check in? Then what happens until they enter your office, and then until they leave. And I would list every single thing that happens at that each step and who does it. And we'll come back to that, why that's really important and why that's helpful. And then I would urge you to come up with a really very specific aim statement, so a specific goal of what you want to work on. So if we keep going with the example of, I want to increase the number of patients screened for cough distress, I've listed some other categories that you might want to work on. That's not specific enough, right? So for example, you might say something like, in the next 6 months, I want to trial something so that my goal of 75% of all patients seen in the office will be screened for financial distress. Or if you're working on actually having the number of cough conversations, I want cough conversations to occur in at least 50% of the patients seen for a follow-up visit, and that be documented in the EHR. The reason to be so specific is that you can then know, well, how am I going to measure it, right? So for the cough conversation, it would be a documented conversation in the EHR. And then you can figure out, is that too much? Like, am I actually going to be able to do that? And if not, then pick a different goal. Then you actually start implementing, planning for the change based on your process map. So that's the map that I mentioned, where you think about what does the patient go through from start to finish? Where is there room? Where does someone have time? So there's not a lot in the literature that I am aware of people actually implementing the screening tool, like different sites, but most of it is done by an MA, for example. So when the MA screens for depression or fall risk, they also screen for financial distress. But that doesn't have to happen there. Maybe there's somewhere else in your particular practice that might be better. And then I would say use the resources that we provide, or the AAFP or other people provide to help you in whatever you implement. And then once you implement it, check the outcomes that you wanted to measure, for example, cost conversations within the EHR, and make changes as you go along. In my office right now, the way we do it is that the individual clinicians actually screen the patients, and we are responsible for identifying patients with distress. We have a pamphlet that we hand out. Oh, and I should point out that NeeDee also has pamphlets that you can just print out for patients with resources listed on them, or you can print out the resources on the ACP website. And then if needed to, we send them to a social worker from the organization. So I would also call your organization and say, what is already available? Where can you send patients to if needed? So I just want to summarize real quickly so that we have time for any questions. So basically, cost sharing is increasing. Patients are paying more and more of the cost of their health care and experiencing more and more financial burden from it. It has significant consequences on their health, and they want to talk to their physician about it. But because of the many barriers that we talked about, these don't happen. I hope that the resources that we have developed, you will be able to not only identify patients that are at risk for financial distress related to the healthcare, but at least can also get them started by sending to some resources or create resources on your own. And with that, I think we do actually have time for questions.
Thank you so much, Dr. Dine. The first one I have is, what happens when patients change health plans midstream? To me, it seems like you might send them back to, or might revisit that treatment plan or the care plan that you talked about. Are there any other strategies that you use?
Yeah, I think that what I've found is, now that I'm actually starting to have these conversations, is that patients feel much better prepared prior to switching healthcare plans. And so they feel better prepared asking for what is this plan going to cover. So I think it has an unintended consequence of helping them be more educated about the healthcare plans. And yes, otherwise you have to go back to sort of going through the calendar. Like I mentioned, typically it doesn't change that much because what I'm giving them is average cost, not specific cost based on their insurance.
Thank you. And have you found any changes or noticed any changes with the patients, or found any adherence problems due to cost, or changes in adherence once you address cost, whether it be to a plan or medications?
Yeah, I don't have a lot in terms of the literature, but my own experience is that I am surprised by how much of the non-adherence is actually related to cost. And, you know, what I hear a lot from my physician colleagues is that, well, we don't want to go to, you know, a plan B because we want to give them the best possible care. And my answer to that would be, well, you know, plan B is better than not doing anything at all. And so I have found that even though I might not be able to do my number one recommendation because of cost, at least I can get them on a second best treatment, and then adherence significantly goes up. I would say that not often is it they're not doing it at all. A lot of the times is they're doing it less frequently. So for example, let's say you prescribe a medication that's twice a day. A patient with financial distress will take it once a day or maybe every other day. And so they that I've seen quite a bit, and I have just recently started asking, do you reduce the number of times that you take your inhaler or medication?
Great question. I think that makes a huge difference in how you pose the question to the patient, what answer you'll get. So even just changing up what you ask about their medications or how you ask it can make a huge difference. I think that's a great question and a great lesson. Those are all of the questions that I have right now. Thank you so much. I really loved hearing a physician aspect on this and what you do in your own practice, and as well as the evidence-based information that you found. I thank everybody for attending, and like I said, this webinar will be available as a recording on the NYACP website. Dr. Dine, before we go, I hate to put you on the spot, but do you have any closing remarks that you wanted to share?
Well, I want to thank everyone for who came on the webinar. I think this is so important, and I think patients will really appreciate it. The one other thing I forgot to mention is that just having these conversations, even if we don't offer a solution, is just changing the culture. And even just having a poster in your office or on your hospital floor that says something like, please feel comfortable to ask me about the cost of your care, is a wonderful way to get started.
I think that's an excellent point and a perfect way to end. Thank you so much, everybody, and I hope you all have a wonderful day.
Thank you.
Thanks, Dr. Dine.